Okay, settle down. I'll start now. Now, I start with the micronutrients lecture. You finished with the macronutrient, that is carbohydrates, proteins, and lipids in the previous term. That is week, I think, 5 to 10 macronutrients. Now the micronutrients, which means you require in very, very small amounts. So, total 5 lectures is there. 1 fat soluble, 2 water soluble, and 2 minerals lectures. So this I'll be completing in the next 2 weeks. And apart from this, I have one more lecture, that is the cancer lecture on effect of cancer on patients. That next week I'll be taking. Today I'll be starting with the micronutrients lecture, that is fat soluble vitamins. You know vitamins broadly classified into fat soluble and water soluble. Fat soluble, you have 4 vitamins A, D, E, and K, and there are 9 water soluble vitamins, which I'll be telling you in 2 lectures of the water soluble vitamins. So today it is the fat soluble vitamins. The learning objectives: you should be familiar with the key food sources for each of the water soluble vitamin. What are the important sources for each of the fat soluble vitamin? And understand the changing needs of the fat soluble vitamins with the age across the lifespan of the persons. Naturally, the requirement for the different vitamins will be different for a neonate, for an infant, for a child, for an adult. So the requirement will be different. And understand the biological basis for the fat soluble vitamin micronutrient deficiency. What causes the deficiency? What can lead to the deficiency? And there is a deficiency, how it will manifest. If you are familiar with their biological functions, you can predict what you expect to see in their deficiency manifestation, and understand the differing requirements of the fat soluble vitamins in different chronic conditions. Now, the amount of the vitamin which you take in the diet, that is known as the recommended dose. You go to any Panda supermarket, you see go to any food section, any nutrient, say a bottle of juice you buy, you turn around, the different micronutrients will be mentioned, and it will be also mentioned percentage of RDA, recommended daily allowances. What is your recommended daily allowances? What percentage that particular food packet covers? Is it clear? So there are 2 doses. One is the recommended daily allowances, and one is the therapeutic dose, the dose which you give for treatment. Recommended daily allowances is for the normal healthy person, not for any disease conditions. But therapeutic dose is for any disease condition. Is it clear? So you should be familiar with the differing requirements of the fat soluble vitamins in different chronic illnesses. Whenever it is illness, it is the therapeutic dose, not the recommended dose. So broadly, there are 4 fat soluble vitamins: A, D, E, and K. This, unlike the water soluble vitamins, the fat soluble vitamins are stored inside our body, and they are toxic in excess amounts. Water soluble vitamins, first of all, they are not stored, and they are not toxic in excess amounts. Fat soluble vitamins are stored, and they are toxic in excess amounts. The sites for the storage are generally the inner organs like the liver, the kidneys, the muscles, the brain, and the fat tissue. And excretion, because they are fat soluble, so naturally they cannot be excreted in urine. So before they get excreted in the urine, they need to undergo some biotransformation reaction. They need to undergo some conjugation reactions which will render them water soluble. Is it clear? Yes. So I start with the first vitamin, vitamin A. Now, collectively, there are different forms of vitamin A. Collectively, they are referred to as retinoids. You must have heard the term. Yes. Retinoid. Particularly in the eye, they have a role in vision, and also very commonly used as an anti-aging cream, retinol, and also for the treatment of acne, pimples, I'll be telling you. So it is consumed primarily mainly from animal sources, and in animal sources it exists is retinol, OL. This is one form. This is the preformed vitamin A. Already it is active. Preformed vitamin. From plant sources, it is provitamin, not preformed. Preformed is from animal sources. And from animal sources, it is in the form of retinol. There are different forms: retinol, retinal, retinoic acid, different forms, carotene. Collectively, they are known as retinoids. Is it clear? So collectively known as retinoids, one form which comes from animal, it is retinol. Is it clear? And it is a preformed vitamin A. They have a role in vision. The first one, they have a role in vision. Apart from this, they have a role in reproduction. They are helpful for spermatogenesis and the prevention of fetal resorption in female. They have a role in growth and maintenance of the epithelial tissues and immunological function as well, role in immunity as well. Retinoic acid, which is formed from the oxidation of retinol or retinal, it mediates most of the actions of the retinoids. So most of the actions of the retinoids is mediated by retinoic acid, with one exception, and that exception is vision. Vision requires the aldehyde form, retinal. Is it clear? The aldehyde form. Now, structure. No need to memorize the structure, but be familiar. There are different parts, different components of vitamin A: retinol, retinal, retinoic acid, carotene, 11-cis retinal, transretinal, different forms. From animal sources, as I told you, it is retinol. It is a preformed vitamin. When it oxidizes, it will form retinal. Why oxidation? You see here it is CHO, here it is CH2, OH, hydrogen removed. So removal of hydrogen is oxidation. So retinol from the animal sources, in animal tissues, it exists as retinal esters with long chain fatty acid. This is a storage form of vitamin A. Oxidized form is retinal, the aldehyde form, derived from the oxidation of retinol or retinal, both. Retinoic acid also derived from the oxidation of both retinal or retinol, both. It is the oxidized form. You see here it is CHO, here it is COOH, one oxygen added. So addition of oxygen is oxidation. Is it clear? Compare it to the retinoic acid with retinol. Here there is two oxygen, here there is just one oxygen. Hydrogen removed and oxygen added. Both are oxidation. Is it clear? Yes. So retinoic acid is formed from the oxidation of both retinal as well as from retinol. From plant sources, what you get is beta carotene. You know carrots, you know very well carrots. They have vitamin A, but it is in the beta carotene form. It is a provitamin, not a previtamin. Is it clear? Pro means it needs to be activated. So, is it okay? Whereas animal sources, it is in the preformed vitamin A. Now coming to absorption and transport in the liver. First of all, don't be afraid by looking at the diagram. Very, very simplified form. This is the intestine, this is the liver. This two are the target. This picture summarizes the mechanism of action, and this is the target. Target, for example, the most common role, it has a role in vision. It forms a visual component of the two pigments, visual pigments in the eye, the rods and cones. You know the rods and cones? It has a form of vitamin A. So the dietary sources can be plant as well as animal. Plant, I told you, beta carotene. Animal in the form of retinal esters. The fatty acid removed, it formed retinol gets absorbed. This beta carotene gets converted to retinal now getting reduced to retinol, again re-esterified with fatty acids, forming retinal esters in the intestinal cell, transported in the form of chylomicron and stored in the liver. From the liver, because it is fat soluble, naturally to be transported in the serum or the plasma, it will require to bind to a protein. So it will bind to a retinol binding protein, and a transport protein goes to the target. For example, the retina, and in the target, it will form the visual component of the two pigments, rods and cones. there is a separate visual, very complicated visual cycle, Wald's visual cycle. I am not mentioning this for you. Is it okay? You just remember it forms component of the visual pigment, rods and cones. Now in the target cell, how does it act? What is the mechanism of action? It is there in the coming slide. You know very well, because it is fat soluble, it can cross the cell membrane and it has the receptor either in the cytoplasm or in the nucleus. You see retinol getting converted to retinoic acid, binding to retinoic acid receptor. So this is the vitamin A receptor complex. It binds to specific regions of the DNA, affecting mRNA transcription, resulting in the synthesis of a specific mRNA with specific protein which will bring about the desired physiological action. Is it clear? Again, I'm telling. The dietary form can be either from plant or from animal. Plant, beta carotene. Okay. Animal, retinol esters. Fatty acid removed. You have retinol absorbed into the intestine from beta carotene. It will first form retinol, then reduced. Here it is opposite. From retinol to retinol is oxidation. Naturally, from retinol to retinol will be reduction. Is it clear? It is reduced, re-esterified with fatty acid forming retinol esters, goes to the liver, stored inside the liver. In the liver, naturally to be transported, it will require a carrier because it is fat soluble. So it binds to a retinol binding protein, goes to the target. Target, for example, in retina, where it forms visual pigment of the rods and the cones. And how it acts, that is mechanism of action. Because it is fat soluble, it has the receptor inside the cell, in the nucleus. So the vitamin A will bind to the receptor. The vitamin A receptor complex will bind to specific regions of the DNA, affecting mRNA transcription, resulting in the synthesis of a specific mRNA, resulting in the synthesis of specific protein which will bring about the desired physiological or the cellular response. Is it clear now? Now, whatever I said in written form, it is there. So, the retinol esters from the diet, they are hydrolyzed in the intestinal mucosa, releasing retinol and free fatty acid. The retinol derived from the esters and from the reduction of retinol from beta carotene cleavage is re-esterified again by the long chain fatty acid within the enterocyte and secreted as components of chylomicron into the lymphatic system, gets absorbed into the circulation and taken and stored in the liver. Now, when needed, the retinol is released from the liver and transported to the blood to the extrahepatic tissues by binding to retinol binding protein. The complex binds to transport protein on the surface of the cells, the peripheral tissues, permitting retinol to enter. As the carries retinol size to the nucleus, where the vitamin regulates transcription like all other steroid hormones. Is it clear? The mechanism also I already told you. So the retinol, through the retinol binding protein entering the cell, getting converted to retinoic acid. It has the receptor in the nucleus, as you can see. So retinoic acid binding to the receptor. Now this is the retinoic acid receptor complex, activated receptor complex, bind to specific regions of the DNA, affecting mRNA transcription, resulting in the synthesis of specific protein to bring about the desired cellular response. I hope it is clear. Any questions, anybody? Now coming to the functions of vitamin E. First and foremost, it has a role in vision. Which component? The aldehyde component. Retinol participates in vision, the component of the visual pigment, rod and cone. Helps in the differentiation of the epithelial cell, maintenance and differentiation. Vitamin A, the retinoic acid form, is essential for the normal differentiation of the epithelial tissue and mucous secretion. It has a role in reproduction. It facilitates the spermatogenesis in male and preventing fetal resorption in female. Sources, animal sources and plant sources. Animal sources, already I told you, preformed. Plant sources, provitamin. Animal sources, liver, kidney, cream, butter, egg yolk, they are the good sources, whereas plant sources, all the colored vegetables and fruits. So yellow, orange and dark green vegetables and fruits are a good sources of beta carotene. That is the pro-vitamin A. Now coming to the deficiency manifestation. First and the foremost, you know what do you mean by night blindness? Dark. When you go to bed and switch off the lights of the bedroom, immediately after switching off the lights, you are not able to see anything. But after 5 minutes or 10 minutes, you are able to make out where the things are kept. Yes or no? Now, the first thing to happen in vitamin A deficiency is there is prolongation of the dark adaptation time. It takes a longer time to adapt to the dark. This is referred to as night blindness or nyctalopia. Is it clear? So the patient cannot read or drive also in poor light. The dark adaptation time, it is greatly increased. If the deficiency continues, it leads to xerophthalmia. What is xerophthalmia? The conjunctiva, it becomes dry, thick and wrinkled. Dry, thick and wrinkled because of keratinization. Also, there is keratinization of the corneal epithelium, and because of keratinization, infections may follow in neglected cases. So, the first thing to appear is night blindness. So, if the deficiency continues, it will lead to xerophthalmia. Okay? And if it continues further, yes?
Low vitamin A leads to keratinization.
No, yes, low vitamin A. Excess will cause decreased keratinization, dry skin and pruritus. It is there in the coming slide. Okay? So, low vitamin A causes keratinization. So, keratinization of the corneal epithelium and infections may follow. And if it continues, you will get this characteristic finding, Bitot spots. Bitot spots, what are they? They are triangular plaques on the conjunctiva. Google the picture of Bitot spots. They are grayish white triangular plaques which is firmly adherent to the conjunctiva. There is increased thickness of the conjunctiva. See the picture of Bitot spots. Is it clear? This is characteristic of, exactly. You can share it in your group, this picture. Bitot spots. Yes, triangular plaques which is adherent to the conjunctiva. Yes. Okay. Now, in neglected cases, if the deficiency continues, it can lead to keratomalacia. What will happen here? So when the xerophthalmia progresses for a longer time, it leads to keratomalacia. What is keratomalacia? The cornea becomes soft and there is sloughing of the cornea. There is sloughing of the cornea. Softening of the cornea and sloughing of the cornea. There is degeneration of the corneal epithelium with vascularization. Normally there is no blood supply on the cornea, no blood vessels. Here vascularizations develop. Okay? There is vascularization. Corneal opacities develop. Later on, because of sloughing, bacterial infection is there. Leads to corneal ulceration, perforation of the cornea and total blindness. This vitamin A deficiency, it is one of the major cause of preventable blindness in the underdeveloped countries. Is it clear? Is a major cause of preventable blindness. Vitamin A. What effects does it have on the skin and the mucous membrane? The skin and the mucous membrane becomes rough because of keratinization of the epithelium of the respiratory, GI or the genitourinary tract. Is it clear? Now, what happens if there is an excess? As I told you, fat-soluble vitamins in excess, they are toxic. So, what happens if there is an excess? The skin will become dry and pruritic. Decrease causes keratinization. So, excess will cause low keratin, decreased keratin. So, because of decreased keratin synthesis, as a result of which the skin will become dry and pruritic, itchy. Now, the liver, it becomes enlarged and cirrhotic, and a very important thing occurs in the central nervous system. There is rise in the intracranial pressure which mimics false brain tumor. In brain tumor, what happens? There is rise in the intracranial pressure. because it affects the CSF drainage, CSF circulation, as a result of which there is increased intracranial pressure. Vitamin A in excess causes increase in the intracranial pressure, which mimics brain tumor. Same clinical features of brain tumor you will get, although there is no brain tumor. A specific term is given to it, pseudotumor cerebri. Pseudotumor cerebri, false impression of a brain tumor. Pseudo means false. Is it clear? Now, vitamin A is to be given with cautious in pregnancy because it has a potential for teratogenesis, causes congenital malformation of the developing fetus. So it needs to be given cautious with females. One form of vitamin which is given for the treatment of acne, severe acne, if given to a female, I'll be telling you, if given to a female, a written consent is required that during treatment they should not get pregnant, that even after stoppage of treatment, that is 6 months, pregnancy should not be there. Yes?
Isotretinoin.
Huh?
Isotretinoin.
Yes, isotretinoin, Accutane. It comes into the market by the name of Accutane. It is there in the coming slides. So, it has a teratogenic potential. Bone, it affects the bone as well, decreased bone mineral density and increased risk of fractures. I hope it is clear now. So vitamin A, the different form, retinol esters, from it you get retinol getting oxidized to retinol, and also carotene getting converted to retinol. The different forms. Now, these different forms, the action as a dietary component, and as a therapeutic agent. Dietary component, the normal dose which you take in the diet, your recommended daily allowances. For that, it is required for the proper maintenance of vision. You require vitamin A for the normal reproduction, for growth and differentiation of the epithelial cells. Is it clear? As a therapeutic agent, you require for the treatment of mild to moderate acne. You know Avotine A, you go to the Lava pharmacy, Avotine A cream comes. It has tretinoin. Tretinoin is a form of vitamin A. It's another form, isotretinoin, which comes in the market by the name of Accutane. It is very potent, and this is given for the treatment of severe disfiguring acne. Some people, they have a severe disfiguring acne. They require this form. For males, no problem, but if it is given for females, a consent is required that during treatment they should not get pregnant. Even after 6 months of stoppage of treatment, this pregnancy should be avoided. Okay? Yes. Which one? Yes, vitamin A recommended dose is safe. No, recommended dose is not in excess amount. Recommended dose is the normal dietary which is present in the diet. It is the recommended dose. Excess amount is the therapeutic dose.
Even if it's not what?
See, you do not take tretinoin or isotretinoin as a diet. In the diet, what is present is retinol, retinol esters, and carotene. Okay, as a therapeutic, you take tretinoin or isotretinoin. Is it okay now? Now, vitamin D. Let me complete. I have 2 more vitamins. Vitamin D. There are a group of steroids that have a hormone-like actions. The active form is 1,25-dihydroxycholecalciferol. 1,25-dihydroxycholecalciferol. This is the active form which binds to intracellular receptor protein. They have the receptors inside the cell. This calcitriol, the active form, or 1,25-dihydroxycalciferol, it regulates the calcium and phosphorus balance. Distribution, from where do you get? There is an endogenous production of vitamin D inside our body, and it is not from sunlight, by the way. Sunlight doesn't have vitamin D. Is it clear? Sunlight doesn't have vitamin D. No, sunlight is required. Okay, sunlight doesn't give you vitamin D. Okay, that's why before I begin, I cleared that out. So, you have cholesterol in your body, it gets converted to 7-dehydrocholesterol. This 7-dehydrocholesterol in the skin, that is dermis and epidermis, in the presence of sunlight, will get converted to vitamin D. So 7-dehydrocholesterol converted to cholecalciferol in the dermis and the epidermis of the exposed skin in the presence of sunlight. You see here 7-dehydrocholesterol in the presence of sunlight getting converted to cholecalciferol. The dietary sources can be from plant as well as from animal. From animal it is directly cholecalciferol, that is vitamin D3, but in plant it is argocalciferol, that is vitamin D2. Now this is not the active form. Cholecalciferol, it is not the active form. What is the active form? 125 dihydroxycholecalciferol, which means 2 hydroxyl group added at position number 1 and 25. So this is the active form. So the formation of 125 dihydroxyl, the first hydroxylation steps takes place in the liver. Enzyme 25 hydroxylase, which will add the hydroxyl group at position number 25. So the first hydroxylation taking place at position number 25. I hope it is clear. The end product of the reaction, that is 25 hydroxycholecalciferol or calcidiol, it is the after the first hydroxylation step, what you get is the 25 hydroxy D3, also known as calcidiol. This is the storage form of vitamin D, the major storage form. So if one is asked what is the storage form of vitamin D, it is 25 hydroxycholecalciferol or calcitriol. Now you must be knowing 80 to 90% of the Saudi population is deficient in vitamin D. When you go for estimation of vitamin D, you estimate this form, calcidiol, 25 hydroxy D3. Is it clear? Not 125 dioxy D3. You measure this one, 25 hydroxy D3, calcidiol. Is it clear? 25 hydroxy, it is then again hydroxylated at position number 1 now, at position by 1 hydroxylase. That is 25 hydroxycholecalciferol, 1 hydroxylase, found primarily where? In the kidney. After the second hydroxylation, you will get the active form, that is 125 dihydroxycholecalciferol. Metabolism. So sunlight, you see here, sunlight is converting 7-dehydrocholesterol to cholecalciferol, vitamin D3. This is not the active form. It needs to undergo the hydroxylation step, first in the liver, second in the kidney. First hydroxylation, 25 hydroxylase forming 25 OHD3. Second hydroxylase in the kidney forming 125 hydroxylase in the presence of 1 hydroxylase. Now this 125 dihydroxylase, it will act on the intestinal epithelial cells, resulting in the synthesis of a specific calcium binding protein which will absorb calcium. Is it clear? So in the presence of active form of vitamin D, that is calcitriol, there will be absorption of calcium from the intestine. Now this calcitriol is formed with the help of 1 hydroxylase. Now this 1 hydroxylase is stimulated by 2 things: low phosphate and low calcium. Low phosphate directly, low calcium indirectly through parathyroid. As you can see here, low calcium indirectly through parathyroid. It is stimulating 1 hydroxylase, resulting in the synthesis of increased levels of OED, increased absorption of calcium from the intestine. In the presence of low calcium only, this and through parathyroid, it will also cause mobilization of calcium from the bone. Is it clear? This mobilization of calcium from the bone is inhibited by calcitonin. Forget about this part. Now, so in response to low serum calcium, there is increased parathyroid, as a result of which there is increased 125 dihydroxycholecalciferol or calcitriol, which will cause mobilization of calcium from the bone, increased absorption of calcium from the intestine, decreased excretion of calcium from the kidney, resulting in also there is increased absorption of calcium from the intestine. So the response to decreased serum calcium is increased serum calcium. I hope it is clear. No problem. So whatever I said, it is there. So hydroxylation, the most potent form is calcitriol, the first hydroxylation taking place in the presence of one hydroxylase in the liver, forming in the liver 25 hydroxylase. Then you have the second hydroxylation, that is 25 hydroxy 1 hydro activity taking place in the kidney. This 1 hydroxylase activity is increased by two things: directly low phosphate, indirectly by low calcium, which increases the parathyroid from the parathyroid gland, which upregulates 1 hydroxylase. So the overall function of calcitriol is to maintain the adequate level of calcium by increasing calcium absorption from the intestine, causing increased mobilization of calcium from the bone, and decreased calcium excretion from the kidney, that is the increasing calcium reabsorption, and stimulating the resorption, that is demineralization of bone from the bone, resulting in increased calcium level. Is it clear? Sources, mainly animal sources, that is fatty fish, liver, egg and yolk. Milk is not a good source of vitamin D. It is, unless it is fortified. Milk is a good source of calcium, but not vitamin D, unless you have fortified means added from outside. Is it clear? Deficiency manifestations. Now, the deficiency manifestation is different in children as compared to adults. In children, it results in a condition known as rickets, whereas in adults, osteomalacia. What happens in children? In children, the ossification centers are not used. So there is collagen formation is going on normally. But with collagen formation, there is no mineralization of the bone. As a result of which, the bone becomes soft and pliable. They get deformed. There is bowing of the leg. You see, Google the picture of rickets. Google the picture of rickets. Yes, see this picture. So this picture. Send it to the group. Send it to the group. Bowing of the leg. Characteristically see, yes. Send this picture in the group. Is it clear? So, rickets. Why this happens? Because there is continued normal formation of collagen, but no mineralization of the bone. So, because of which the bone becomes soft and pliable, it gets misshapen. It takes the shape of a bow. But in adults, the ossification centers are fused. Okay, the collagen synthesis is normal. So what happens? There is now demineralization of the bone. There is demineralization of the bone. This demineralization will result in weak bones, which tend to fracture easily. So this is referred to as osteomalacia.
Doctor,
Yes?
What is the difference between osteoporosis and osteomalacia?
Osteoporosis is hormonal. Same thing. Osteoporosis is hormonal, occurring at a age, after a certain age, after 15, female or elderly male. Yes.
doctor, one of its manifestations, could it cause depression?
Which one?
Vitamin D.
People say some people linked it, but it is not proven yet. Not. Now, yes. When you take high doses, 100,000 international units for weeks or months, then you tend to develop hypervitaminosis D. Now, normally when you have vitamin D deficiency, you are given weekly 60,000 units, 60,000 international units for 8 weeks, and then 2 to 5,000 every day for 2 months. This is normal, but when you take 100,000 for weeks and months, then you tend to develop vitamin D excess, that is hyper. It is characterized by loss of appetite, nausea, thirst and weakness, and it will cause enhanced calcium absorption and bone resorption, as a result of which there will be increase in the calcium levels, hypercalcemia. which will be deposited to other places. So this is metastatic calcification. Metastatic means other places, not cancer. Yes?
It can cause stones in the kidney, right?
Yes, yes. That is right. This is because of calcification taking place in the kidney. Is it okay? Now vitamin K. Vitamin K. Now whenever you hear of vitamin K, it is related to clotting. Blood clotting. It is required for clotting. It serves as a coenzyme for the carboxylation of glutamic acid residues. Glutamic acid residues is present in some of the clotting factors, 2, 7, 9 and 10. I'll be telling you. So this requires carboxylation to be functional. So vitamin K, it exists in three forms. K1, K2, K1 from plant. K1 from plant. Remember, K1 the form is phylloquinone. P for plant, P for phylloquinone. Remember like this. Is it clear? K2 is synthesized by the intestinal bacteria. K2, menaquinone. Menaquinone. K2, intestinal bacteria. So naturally, in any condition where there is a decrease in intestinal bacteria, there will be deficiency of vitamin K. Which condition do you think that there will be a decrease in the intestinal bacteria? Yes? Yes, antibiotic. Taking a broad spectrum antibiotic. What happens? Can you close it? Okay. Now, a synthetic form available in the pharmacy is menadione. This is converted inside our body to K2 form, that is menaquinone. Now, functions, as I told you, understand this. The clotting factors 2, 7, there are number of clotting factors all made from the liver. Okay, this you will be taught in your hematology module. I will be taking in third year. Of this factor 2, 7, 9 and 10. You see the Roman numbering? 2, 7, 9 and 10. 2 is prothrombin. Okay. 2, 7, 9 and 10. They have glutamic acid residues. This is glutamyl residues. The numbering of the carbon. The first carbon is alpha, then beta, then gamma. You see one carboxyl group? Here, what happens in the presence of vitamin K, the second carboxyl group is getting attached. And it is getting attached to position gamma. Is it clear? After this carboxylation reaction, you get the mature clotting factors. The factors, the clotting factors which will be useful for clotting. So vitamin K is required for the hepatic synthesis of the blood clotting factors, that is factor 2, 7, 9 and 10. 2 is prothrombin, as I told you. Formation of the functional clotting factors requires vitamin K dependent gamma carboxylation at the gamma position. Carboxylation means addition of carboxyl group. You see carbon dioxide getting converted to carboxyl group and getting attached where? Gamma position. Is it clear? This carboxylation is essential for the clotting factors to become functional. So this carboxylation requires the enzyme is gamma glutamyl carboxylase and vitamin K. Naturally, this vitamin K, if there is a deficiency, what will happen? The clotting factors will not be formed, so there will be impaired clotting. Is it clear? This step, this vitamin K dependent gamma carboxylation is inhibited by the oral anticoagulant. Have you heard of this warfarin? Yes. Warfarin is an oral anticoagulant. How does it act? It acts by inhibiting the vitamin K dependent gamma carboxylation of the 4 clotting factors, that is 2, 7, 9 and 10. I hope it is clear. Now, what role, how does it exactly act? Prothrombin needs to interact with the platelets for the clotting to occur. Now, you see this? These are the clotting factors, precursors. Why precursors? They do not have the carboxyl group. Here the carboxyl gets So these are the active form in the presence of vitamin K. So the GLA residues, they are good chelators of positively. So this will chelate or interact with calcium, which is present on the phospholipid bilayer of the platelets. So this will result in aggregation, activation, and clumping of the platelets, which will initiate the coagulation cascade. So it will help you in clotting. Is it clear? So the prothrombin means factor 2 calcium complex is able to bind to negatively charged membrane phospholipids on the surface of the damaged endothelium and platelets. So attachment to the membrane increases the rate at which there is the conversion of prothrombin to thrombin. Thrombin means clot formation. Is it clear? Clinical indications. When do you give? Normally, you do not require vitamin K because adequate amounts are present in the diet. Therapeutic doses are not recommended. So deficiency of vitamin K, it is unusual because the adequate amounts are present in the diet. Deficiency occurs, as you rightly told, if a person is taking a broad spectrum antibiotic, because the K2 form menadione is synthesized by the intestinal bacteria, and the broad spectrum antibiotic, it disturbs the normal bowel flora. Deficiency occurs in the newborn. Why? Because the newborn intestine is sterile. They do not have. So deficiency occurs in the newborn. So it can lead to deficiency in the newborn because the bacteria which is responsible is not present in the intestine of the newborn. So all newborns, as a routine procedure, they are given intramuscular injections of vitamin K to prevent vitamin K deficiency. In excess amount, vitamin K will result in hemolytic anemia because in excess it is toxic to the RBC membrane, and because of hemolysis it can lead to jaundice in the newborn. What is jaundice? Why skin skin? Why? Okay, liver problem means what? There are many liver problems. Yes, bilirubin. Bilirubin coming from where? From the RBC. RBC when broken down, heme and globin. When heme broken down forms bilirubin. And bilirubin is metabolized in the liver. Is it okay? So because of this, there will be jaundice in the liver, and also hemolysis will be there because of toxic effect on the RBC membrane. Now the last vitamin E. This consists of naturally occurring 8 type of vitamins which are collectively referred to as tocopherol. Tocopherol. So when I am talking of tocopherol, it is vitamin E. This function as an antioxidant. You know antioxidant? They help in neutralizing free radical which cause oxidative tissue damage. The most common form of antioxidant, vitamin C. Among the fat soluble, this is the most potent, vitamin E. So it is helpful in the prevention of the non-enzymatic oxidation of the polyunsaturated fatty acid, preventing injury against molecular oxygen, which have an additional pair of electrons which cause oxidative tissue damage. Sources, vegetable oils, liver and milk are the fit sources. The recommended dose is 15 milligram per day, but this is one of the safest fat soluble vitamins. So deficiency doesn't occur even in very high doses. So the vitamin E requirement increases as the intake of polyunsaturated fatty acid. If you are taking more amount of polyunsaturated fatty acid, then the requirement for vitamin E is more, naturally to neutralize this. Newborns, deficiency occurs in the newborns because they have a low reserve, and the newborn babies are given supplements to prevent hemolysis and retinopathy. Yes. The retinopathy associated with vitamin E deficiency. It is involved in the defective lipid peroxidation because it acts as an antioxidant. So deficiency is associated with defect in the lipid absorption and transport. What is the clinical indication? When do you think vitamin E is given? It is generally given for heart patients. Why? Because it prevents the oxidation of LDL. Oxidized LDL leads to atherosclerosis. So it prevents the oxidation of LDL. So oxidized LDL promotes heart disease by causing Atherosclerosis. You know atherosclerosis? Toxicity, as I told you, it is the least toxic of all the fat soluble. The recommended dose is only 15 microgram, but even at 300 microgram, toxicity symptoms are not seen. So it is the least toxic of all fat soluble vitamins. Now wait. Now this is the table for last minute revision. It summarizes everything what I told you just before entering the examination hall. So vitamin A, the different forms: retinol, retinal, retinoic acid, beta carotene. Vitamin D, the different forms: cholecalciferol and argo. Argo from plant, cholecalciferol from animal sources. Vitamin K, menadione, menaquinone, phyloquinone. Phyloquinone is K1 from plant, menaquinone from bacteria, and menadione commercial. Is it okay? And vitamin E, is it okay? Active form, I told you, retinol, retinoic acid. Active form of vitamin D, 125 diadeoxy. The same active form for vitamin K. Functions, already I told you, in a tabulated form. What deficiency? First deficiency to occur in vitamin A, night blindness. Yes?
I thought the active form of vitamin A was retinol.
No. Active form, all. Yes. Beta carotene is not the retina, except beta carotene. Okay. Now this is the deficiency. Signs and symptoms. Toxicity. Yes, vitamin A and D is toxic. K and E, and the special notes added to it. So this is for the last minute revision. With this I complete. This is your reference. With this I complete. I complete in time.